Good morning, everybody, and welcome to this webinar, Improving Suicide Prevention Through Enhancing Access to Care. This is part of a webinar series that the WHO Regional Office for Europe has been conducting this year called Enough Waiting, Reshaping Mental Health Care. We have a really exciting lineup for you today. A lot of expertise from across the world with a specific focus on Europe. And we will be exploring suicide prevention through all of its aspects from the primary, secondary, and tertiary care and the complexities of working across different sectors in order to make this a reality so that we can continue the observed trend over the last few decades of an overall reduction in suicide that is unfortunately not happening as fast as we would like it. But as you'll hear today, it is happening, and there's a lot of expertise being put into this area, and there's a lot of passionate people who are going to be talking to you today about what they have done. A few things before we get started, and I hand over to my colleague Lydia Lazzeri. I'm also joined here by my co-host Giulio Castelpietra. And to introduce myself, I am Jason Maurer, and I am a communications and advocacy consultant working with the WHO Regional Office for Europe. If you have a question, please share it in the chat or using the Q&A feature of Zoom, and we will do our best to get to it. If that is through verbalizing it and having it answered by one of our panelists or speakers, or answering it in chat, please don't hesitate to bring up any questions you might want. This webinar is being recorded, so please acknowledge that that is what will be happening. And if you want to watch it later, then please reach out to either myself or Giulio. We will be sending a follow-up email. With that said, I would like to hand over to my colleague, Lydia Lazzeri, who is the Regional Advisor for Mental Health at WHO Regional Office for Europe, to introduce the webinar for us. Lydia, over to you.
Thank you. Thank you, Jason, and thank you, Giulio, for your tireless work behind the scenes to make this webinar happen. A very warm good morning, good afternoon to everybody. I am happy to see the number of attendees of this seminar is going higher. So thank you for giving us the time of the day. And thank you also to the panelists who have set aside their time since a while ago to join us in this very important event to observe the World Suicide Prevention Day, which, as you all know, we observed actually the day before yesterday. This webinar is part of a series of webinars that we are organizing in frame of a contribution agreement we are having with the European Union, the DG Sante, the European Commission, that is actually aiming at addressing mental health challenges in the countries of the European Union and Norway and Iceland. Now, why I say that, it's because it's important to see that this series of webinars is not only dedicated to improving access to mental health care in Europe. No, the name of the titles, the webinar series is Enough Waiting, Better Access to Mental Health Care, but it's also combined with larger efforts to promote better policies for mental health services and to foster better collaboration in between the various government sectors and with the various non-governmental stakeholders. And I'll talk about that in a minute. As you all know, suicide remains a public health concern, with the almost 47,000 suicide deaths in the European Union. We have 47,000 too many deaths in our region. I would like to share with you, I had just started to work with WHO in the year 2000 when Professor Danuta Wasserman just published in 2001 her book called Suicide, an Unnecessary Death. And that has profoundly marked my professional growth, reminding us that suicide is unavoidable death, and there are so many things that society, including mental health workers, policymakers, persons with lived experience, can do to address this public health issue. We have seen a drop in suicide in the European Union. Actually, during the last decades, we have seen a drop by 13% decrease. And this is one of those indicators in the SDGs. You may be aware, those of you who work with governments may be aware that in the Sustainable Development Goals, the only mental health indicator that is there across more than 130 indicators is actually suicide, the suicide indicator. And we're happy in Europe to have seen a drop in suicide. However, we must notice that the progress is uneven. There are some countries who have achieved very good progress, and there are some countries who are still struggling with curbing their suicide rates, which is, while it is encouraging, the drop by 13% of suicide in the European Union is very encouraging because it tells us that the strategies work, so that the policies and the strategies that have been enforced to address suicide have worked. So that is encouraging. But still, the 47,000 deaths that we see in the European Union and the more than 720,000 deaths that we see globally remind us that action still needs to be taken at all levels. And in that sense, as part of this collaboration that we are having with the European Commission, we held in Paris, together with the French government, the French Ministry of Health and Access to Care, we held the first high-level conference dedicated to mental health in all policies. And this is where we talked about the importance of having all sectors of society, of governments, be those education, be those social welfare, be those finance, be those agriculture, be those employment, or any other sector that I haven't, urban planning, for instance, need to be involved into making life better for their citizens in terms of mental health, but also, and by proxy, in addressing the suicide as a public health concern. As important as all the efforts to prevent suicide are the efforts for postvention interventions, so to enforce postvention interventions. They are critical for people who have attempted suicide, but also who are bereaved or affected by a suicide. As we know, every completed suicide counts for 20 attempted suicide, and therefore postvention is as important, as critical as prevention efforts. And in that sense, reaching out to family and friends after a suicide, either a completed one or an attempted one, provides immediate support, provides relief, can help reducing emotional distress, depressive and anxiety symptoms, and of course, it can address the risk of imitative suicidal behaviors. There is a lot to do. I mentioned few sectors. One thing that WHO has been good at is, for instance, proposing strategies in working with media. And I'm reminded of that because I mentioned the imitative suicidal behavior. So WHO has a wealth of advice to offer to societies, to national, local stakeholders in how to work with media, how to partner with media so that the suicide efforts are done collectively. Another challenge we have is that, of course, due to digital penetration, media is no longer the mainstream media, but it's very much moved into the social media sphere. And we are experiencing the moment when the proliferation of AI technologies is now signaling some bad practices where teenagers, vulnerable children and teenagers have managed to complete suicides as guided by some algorithms. So the challenges ahead are huge. There is a lot of success, which is encouraging because it tells us that there is knowledge, there is evidence to guide us in our future efforts, but there are also newly emerging determinants that guide us, that pressure us into being innovative, into being creative to address those newly emerging determinants. With that, I know that today will be exciting, and I again thank very much not only those who are attending to listen to what our speakers have to say, but also to our panelists, not only for giving us the time of the day, for all the work you do in your countries with passion, with dedication, and with credibility. Back to the moderators, and thank you again for today.
Thank you so much, Lydia. I think that that was a wonderful introduction to um, the webinar, and it showcases the passion and the hope, I think, that we all in this field feel in driving change. And hopefully that at one point we can say with confidence that um, suicides are reducing at a rate that we are proud of. Um, I would like to now hand over to our keynote speaker, who is Sanderson Onye, who is from our WHO headquarters in Geneva. He is a consultant on suicide prevention, and he will be here talking to us about the lay of the land with a little bit of a focus on Europe. Sanderson, over to you.
Thank you so much, Jason. Good morning, everyone. My name is Sanderson Oni, more commonly known as Sandy. And I just wanted to echo what Jason was mentioning is how lucky are we in the Euro region to have a regional advisor so passionate about suicide prevention. I think especially when it comes to suicide, we cannot afford to depersonalize something that is so personal to all of us. We cannot afford not to be passionate about something that affects people in such deep levels throughout their lifespan. And so it's my incredible honor today to be able to speak a little bit about a multisectoral approach to suicide prevention with a focus on some of the topics that were raised in the European region. So I have 20 minutes. That being said, we're not going to be able to cover the entire breadth of all of suicide prevention in 20 minutes, but I'm hoping to touch on a couple of topics today that may be helpful for the region. So I'm just going to share my screen. Just checking. All good, Jason? Terrific. So well, Lydia's already said before that according to the latest global health estimates, that over 720,000 people die by suicide each year. And we know that the statistic in the Euro region is 49,000. And again, that's 49,000 deaths, far too many. And the weight of that, to imagine that we take that number and multiply it by 20, that's the number of individuals who are brought to the point where they feel they need to take their own life. That is the distress, the collective emotional distress of what we're seeing across the European region. And we know that is one of the leading causes of death for young people in Europe, where it's the younger generation that's being robbed of their futures, of their lives, or future experiences by self-harm and by suicide. And so in response, just briefly as well, we know that suicide is the only mental health indicator in the UN SDG 3.4.2, meaning that is highlighted specifically because of the impact on the population that we need to reduce suicide mortality. And is also highlighted in the WHO General Program of Work 2025 and 2028. So very briefly, this is our Live Life framework, the Live Life initiative that the WHO uses to prevent suicide. And some of you might be familiar with this. In fact, I think some of the people here, especially some of the panelists, might have even worked on this together. And this is the framework that we use when thinking about national suicide prevention strategies. Now, the reason for that is we know that suicide is so incredibly multifaceted that it doesn't only span one specific area, but it needs to be tackled by so many different sectors that only through a strategic, coordinated approach by different stakeholders, by different players, that we're able to reduce suicide. In addition to that, we know that the situation from one country to another is so different. In fact, through my time as an academic in WH, I've had the privilege of working in suicide prevention in over 40 countries, each in very unique cultural settings, very unique in terms of its social determinants. But what we're seeing and what we've distilled within the Live Life initiative and approach is this, where there are 4 key interventions We know that limiting access to means of suicide is incredibly important because individuals who are in a point of crisis, if they're unable to access their preferred suicide method, that we might be able to delay and we might be able to help them. In fact, recently in the International Association for Suicide Prevention World Congress in Vienna, where I also had the pleasure of meeting Professor Annette Erlangsen there, there was a keynote speaker or a plenary who talked about how time is a protective factor, where we can delay the suicide, we can prevent the suicide from happening, that perhaps a lot of the people over time will not reattempt again. Some will, but a lot of them actually won't. We heard from Lydia before that interacting with the media on responsible reporting to prevent suicide contagion, to prevent imitation suicide is incredibly important because the last thing a person needs at a time of distress is to hear about time and methods about suicide. And so we know that the media landscape is changing very quickly. Not to mention now it's changing as rapidly as ever with the introduction of large language models and AI, where the access of information, that the attention economy is making it easier for people to access information that may be harmful to them. Because we know that what a person wants to read may not be necessarily what they need at that moment. In addition to that, we talk about fostering life skills of young people we with the hope is that if we're able to build these socio-emotional skills, and now it's actually expanding where some countries are going beyond social-emotional skills to even things like financial literacy, because we know that economic downturn is a major associative factor to increase suicide rates, where if we can equip them young, then the idea is to have a protective nature later on in their lifespan. And last but not least, the early identification and management of everyone affected, including those who are bereaved by suicide, making sure that every person, we'll talk about this a little bit more later, is able to turn to someone or somewhere close to them and say, I need help. Because with all these strategies that we have, it boils down to each individual person being able to find that place where they need help. Now, of course, putting these strategies together, these interventions together, is no mean feat. And so we have these cross-cutting foundations where we understand we need a situation analysis. And this is an ongoing living document because especially now in Europe, we know that the population makeup is changing very rapidly. We know that many different factors are shaping social determinants, which are major components to suicide. We know that awareness raising, and in fact, the World Suicide Prevention Day theme is changing the narrative. What I often find is that we're raising awareness again and again and again without realizing that oftentimes where we're still in a bubble, that a large part of the population still has their own thoughts and perceptions about suicide and suicide prevention that make it difficult for them to reach out and ask for help. We know we need to have capacity building where the people who are part of the strategy need to be capacitated. We need to have sustainable financing. We know that financing and resourcing is always a really big issue because it really depends on political will. In fact, in one of the countries that I work with, they have a stellar national strategy, and yet the next budget that came out didn't feature the strategy. And we know that's a problem that we're seeing quite a number of places. And last but not least, we know that we need to have surveillance monitoring and evaluation. Now, some of you might be thinking that we're looking at this and it seems relatively basic. And that is true because, in fact, Live Life is not the be all and end all of a national suicide prevention strategy. It is the foundation of one. And so the way that we think about it, the WHO, is not that you only need to have four and you can't have anything else outside. Absolutely not. But rather, we want to make sure that it is evidence-based interventions that form the foundation of a national strategy. And thus, that's where we build on Live Life, but then it flourishes and grows beyond that to each national and independent context. Now, going into the crux of what I'd like to talk about today, I had a lovely conversation with both Julio and Jason, and I asked them what's happening in the European region? What conversations have you had in the past? What are the challenges that the member states and the countries are facing? And so we're going to talk a little bit about that today. We're going to talk about improving access to care through a multisectoral collaboration. I'll go through a couple of principles, and we'll have some case studies in between and one more at the very end. So we talk about access to care. Now, we know that in the European region, there's a very heterogeneous spread of countries in different situations, in different conditions. But one of the principles that we found in working in different countries is that there's a huge amount of variability in the population. We know that the label, high income country, middle income country can often be deceiving, can often be misleading. And in countries that we look at have a high GDP and might be able to, and in certain places, have the most brilliant access to care, that there are still some populations that aren't able to experience that, that aren't able to enjoy that level of access. And in fact, that we talk about differences between countries, but in order to get the suicide rate down even further, and that means thinking on an individual level. So we've often, when we look at the progression of suicide prevention through the ages, we go from an individual level to a public health approach. And now I think it's time for us to go back to the individual. And we know that suicide and social determinants, factors pertaining to suicide are absolutely not evenly distributed within a country. And thus, it's important to understand who is dying by suicide. And is the same group that's dying by suicide that quote unquote seem resistant to the efforts that we've been trying to implement, that may not be able to, that what we're doing may not be able to reach these populations. Is it the same people year after year? What are the population trends? What is the change in geographic distribution of suicide? What is it, the change in methods? Although we might see slightly smaller changes there. And here's the important thing where one of the things that I've seen in countries that have managed to reduce suicide well is not only the fact that actually did what they said that they would do in the national strategy, but also to have an implementation process where it's national direction to local support to individual empowerment. In fact, one of the countries that I see doing this incredibly well is Japan, where what they're able to do is their national office is able to send personalized suicide statistics and recommendations to every single local district to empower them to act in a local manner, understanding that one district is different from another. Because in the end, the reason we go from national, local to individual is because if a person is thinking of ending their life, it doesn't matter how good the national strategy is a lot of the time. At the end of the day, you can have these national strategies that are multisectoral that have been signed by different ministries, but at that time, can that person turn to someone next to them? Or at that time, can that person go to a place where they feel safe, where they feel heard, where there's empathy? And that's why national direction needs to work all its way down to individual empowerment. This is where, and I'll touch on it again, lived experience is so important. Because oftentimes, what I found, what we see on paper, and I think a lot of us here have such incredible broad purviews in our national scopes that things might look differently on the field. That's how it's been for me a lot of the time, where I was recently in rural Bangladesh, where some areas do it really, really well. But when we talk to the people who've received these services, there seems to be key barriers, which leads me to my second point that availability is not always accessibility. That funding a program and making sure that it's accessible to people rather than just available are two very different things, two very, very different concepts. And we know that there are certain barriers that are sometimes external, but also really internal for a lot of people to access the care that we're providing. Where this is the interesting thing. What I've seen in a global landscape is that we don't usually use the word culture a lot in American and European regions. We often think of culture as something that is unique, that's different from us. We use the word a lot in the Southeast Asia region and some of the countries in the Western Pacific, sometimes in the African region. But oftentimes we're blind to our own culture. And so having a strong understanding of what are the cognitive barriers that people have within their own culture and beliefs is an effective way to ensure that the population that may not be responsive to what we've been implementing so far are able to access the care that they need. Again, that lived experience must be integrated at all levels of decision making. And what this looks like is ensuring that there's a voice, there's a place where people with lived experience can give feedback. I know this isn't always easy. I think that in a lot of the efforts that we've implemented and I've implemented over the years, that sometimes feedback may not be the nicest to sort of hear. But if we want to be able to prevent suicide, we have to be open to integrating lived experience, to understanding that. And funnily enough, at least in my own experience, where it's been incredibly humbling that we've missed some very obvious things that people with lived experience have pointed out. That we have certain framing, we have certain messaging. We say, okay, we're going to create these safe havens, we're going to create these helplines. And they'll tell us later that, Sandy, not everybody wants to call a helpline. Can you at least give us some text before that to explain the anonymity and confidentiality of it before we call it. Very simple things that I thought that I'd covered. Another one is understanding touch points. And what this means is that for every single individual living in a country, there's a finite and limited number of times that we can reach them. And that goes back to what Lydia was talking about in social media, where they talk about the economy, no longer information economy, where it's not difficult to find information, but rather in the attention economy, where we're vying for attention. And so, for example, for all the people here, including the panelists, if I said, here's this genie lamp, thinking also of Aladdin, and you had one wish, you were able to get a single message out to the entire population, what would that be? And what that means is we have to understand that there's only a very limited and finite number of times that we're able to get a message out to the population pertaining to suicide, pertaining to destigmatization, about health provision, and all of what we're advocating for. And we need to use each time and each moment as effectively as possible. And oftentimes we think about healthcare systems, where, for example, there's a study that came out, a systematic review that was published, talking about how an individual will see a doctor so and so weeks before they attempt suicide. We have to think broader. We have to think about how we are reaching people through the internet, through certain places where their place of work, their place of residency, their place of where they have leisure, not intrusive and respecting their privacy, but understanding that each touch point is incredibly important. So, for example, one of the programs that they did in rural Australia that I found was incredibly inspiring is that we know that men die by suicide at a disproportionately higher rate than women. And we know that in rural areas, the means may be a little bit more lethal and there's less help seeking. So what they did there is they thought, okay, what touch points do we have? And in fact, what they did that I thought was incredibly brilliant is they taught counseling to the barbers, because they found that through lived experience consultations, that one of the very few places that men were able to talk about their feelings without stigma and judgment within that context was when they're getting their hair cut. You're sitting there for maybe 20, 30 minutes, somebody's cutting your hair, somebody's giving you a shave, and that's when they're able to talk about what they were going through. And so understanding these key populations, the variability, understanding that just because something's available to them, it may not be accessible, integrating lived experience and understanding at what point are we able to reach them. That's where we might be able to reach that population that might not be receptive to what we've been implementing thus far. And that's why suicide prevention needs to have a strong grasp of the evolving local situations, who and why they need help, and how to best reach them. And task sharing, talking about sustainable mental health, published by previously the lead at WHO headquarters, as well as Professor Vikram Patel. Professor Shekhar Saxena is incredibly important to understand task sharing within the context of suicide prevention. We then look at multisectoral collaboration, which I understand is one of the challenging touch points here in the Euro region, where the frustrating thing I find about suicide prevention is that it's incredibly multisectoral by nature, meaning that the healthcare system is imperative. It's so important to preventing suicide, but it cannot prevent suicide alone. And in fact, when we look at the data, that the most effective way to prevent suicide on a population level is means restriction, is that, and we talk about pesticides in many different countries, meaning that we cannot prevent suicide without their collaboration. And so the way that I see the healthcare system is providing a strong foundation for suicide prevention, but also at the same time, ensuring that there's collaboration and influence across the different sectors. And let's talk about how we might be able to do that. As I mentioned, there are very few health issues as holistic as suicide prevention. But then also when we talk to different governments about, and a lot of governments have come to us and saying, Sandy, it's difficult to reach other sectors. They're establishing their work plans. They've established their budgets. How are we able to influence that? So I think that what's important for the suicide prevention sector is to understand where we lead, where we collaborate, and where we influence. And there's a very strong distinction between these three. In the same way, when we lead, perhaps, crisis management, we're able to ensure that a person walks into an emergency department, that they'll leave receiving adequate care. and that we follow up with them as per MHGAP guidelines. We collaborate with the agricultural sector, with the media sector, with the police to ensure that individuals aren't exposed to harmful materials, whether through information or through means of suicide. But now recent evidence is emerging suggesting that some of the most effective way to prevent suicide is the influence in terms of social determinants. We talk about welfare support. We talk about helping individuals preventing suicide through preventing early childhood trauma. We talk about financial literacy. Now, these areas might seem rather distant from the suicide prevention sector, but whether we like it or not, being able to influence them and aiding them into developing these plans while having our own suicide prevention agenda is effective to suicide prevention. And that's one of the challenging things where what we're trying to do, we need their collaboration and we need to be able to influence some of those policies as well. And so talking about strategic influence, that if a sector will not engage, I think given the weight and the importance of suicide prevention, we have no other choice than to change our approach. We understand that their interest may not be our interest. In fact, suicide prevention is one among hundreds of different health issues, even within the health sector. And so for those of us who are struggling to engage different sectors, one of the things that I found helpful is to understand pen on paper, what is their government mandate? What are their KPIs? What is in legislation asking them to do? And how can we support that while actually having our own agenda to prevent suicide? And often what I find is that there's a divide between technical and political roles, where we often use this language within the WHO, and I know in many different government sectors, but technical often has the knowledge and know-how, but political is the one that can influence change. And what we often see is that we have people with the technical know-how trying to influence political changes, because that's what we need when we're working multisectorally. And so there needs to be a collaboration between the technical and the political roles within each government sector. Even within the WHO, we know that we need to collaborate strongly between the technical and political roles to affect this change. And so that's what I would encourage for there to be increased communication. And the thing is, suicide prevention is so broad. How we engage in activities needs to be varied depending on political situation, sectors, and each sector's interests. So if you're struggling, so for example, in one of the countries that I work with in the agriculture sector, um, and this is an example that may or may not be pertinent to Europe because I know that certain methods are different from one region to another, but I think the example stands the same, is that they ask them, okay, we want to ban certain highly hazardous materials. It could be medication as well. And when we ask them, they say, oh, we're not interested in suicide prevention. That's not on the top of our list. And we ask them, okay, so what are you interested in? They say, you know what? We're actually interested in, and the terms that they use was general misuse, general safety, and general misuse. And from then on, every single technical document, every single point of advocacy we had used those exact terms. Why? Because it made it a lot easier for them to then feed it back into their KPIs and to their objective key outcomes. I just wanted to give an example of something that I was involved in, where when we think of suicide prevention, we don't often think about religion. And so in the country of Indonesia, one of the largest countries in the world, they had terrific mental health and suicide prevention legislation dating back to the 1960s, leading the Asia Pacific region. But there was very little progress then. They experienced similar challenges. They tried doing things, people weren't responding. They had difficulty with financing, multi-sectoral collaboration was difficult. And then they asked the question, what levers could we pull in the society to make this change? And in fact, and every country is different, even within a single region. And this is what I would encourage each person to ask about their own country. What levers can be activated? Who holds public opinion? Who holds governmental power? And it so happens in the country of Indonesia, it was religious leaders. So as part of the G20, the religious leaders signed a declaration with underpinning theology to talk about how important suicide prevention and including surveillance is for religion in that country. Within 2 years, suicide prevention got into national legislation for the first time in history. There was legislation coming out the next year which talks about a suicide registry. And there is already talks about being able to, where previously this wasn't the case. It's coming through now on a presidential level to be able to cover self-harm and suicide attempts using universal healthcare. Now, the example might be vastly different from your country, but it stands to reason that there are levers within each society, which in each country, that if you're able to activate the right people, the right levers, you might be able to see the change that you'd like. And last but not least, our call is to prevent every suicide we can. And why is it so important to add the last two words? Because we understand that suicide prevention is one of the few health issues that talk about what it means to be a human being, more so than a lot of other health issues. And it's so multisectoral that it's not feasible in every single country, in every single context, to get the outcomes and results that we want. So a call to each of the people here, and especially to prevent burnout, is remember our call to prevent every suicide we can, and to continue doing our best. Thank you very much.
Thank you so much, Anderson. That was a brilliant presentation. And I think that ending on that note of what can we do and how can we utilize the levers that are within each of our countries in order to prevent suicides that we can, I think is something we should take with us as we go through the rest of this webinar and hopefully beyond. I would like to hand over now to my colleague, Giulio, who will be leading the next part of the webinar. Giulio, over to you.
Thank you a lot, Jason, and thank you, Sandy, for the wonderful presentation. It was setting perfectly the table of our discussion next. Just a technical thing, we have no time in this moment for Q&A. We will dedicate a room for all the presentation and speakers at the end of the webinar, so because we are running a little bit late. So I introduce myself a bit. I'm a consultant for the WHO Regional Office for Europe, and I'm a psychiatrist at education. It's a pleasure to be here today for facilitating the first panel discussion and help extend the discussion on the importance of multisectoral approaches to suicide prevention. For dealing with this, we have in this panel discussion 3 technical experts who will bring precious thoughts and experiences on this subject that was introduced by our key speaker. So these 3 persons are Anton Grech from University of Malta, Shaska Roskar from the National Institute of Public Health in Slovenia, and Annette Erlangsen from the Danish Research Institute for Suicide Prevention in Denmark. So, as Sandy outlined so clearly, multisectoral collaboration is a key issue to consider in suicide prevention, and it should be declined firstly to the national level to reach then the local and individual level. So let's begin thus with talking on example of national suicide prevention strategy where a multisectoral approach was a key point for elaborating them. So let's start with Dr. Grech. What motivated Malta to develop a specific national suicide prevention strategy, and what was the process? Thank you. The floor is yours, Dr. Grech.
Hello. Thank you for organizing this seminar because it's a very important subject. First of all, I wish to make it clear that for us, any action which improves mental health and any action which decreases mental illness, it's a step towards suicide prevention. So the more the services get better and the more there is education, it's suicide prevention. Having said that, we saw that it is important, that suicide is such an important matter, that there is particular focus on it as well. It has an individualized strategy on it. Within, we already had a mental health strategy, so we wanted to incorporate the suicide strategy, particular emphasis within the mental health strategy. There was a decision, we made the strategy, and we collaborated with a lot of people. Maybe later I'll have time to talk about that. The strategy then was presented to the cabinet of the ministers and the prime minister. It was approved, and it was approved for consultation. So we had a 6-week consultation period with the general public. After those 6 weeks, we have analyzed again the feedback we had, and now the strategy is in the hand of the prime minister and the cabinet to approve it, and obviously to provide finances, not only to approve it. That's the whole. But again, the main thing I wish to emphasize is that we have done this not in separate from the mental health strategy. It's very important that improving mental health of the population and treating mental illness in itself is suicide prevention strategy, because sometimes I get worried that people speak as if they're speaking on two different things. Thank you.
Thank you so much, Dr. Grech. So one of the key aspects of a strategy is also ensuring a greater access to care for people with suicidal behavior. So the second speaker is Pascal Rosker. So in Slovenia, there is not a specific national suicide prevention plan, but suicide prevention activities are embedded into the national mental health program. This did not hinder a suicide prevention strategy with using a multisectoral approach. So how did you approach on suicide prevention, strengthening access to care from a multisectoral point of view in Slovenia, Dr. Rosker? Please, sorry.
Hello, I hope you can all hear me well. Thank you for having me and inviting me so I can share a little bit of experience from Slovenia. Just to share a brief statistics from our country, Slovenia is a high suicide rate country, but nevertheless, we witnessed a 30 to 40% decrease in the last 20 to 30 years. What's intriguing is that most of this decrease happened in a time frame when we didn't have any national either mental or suicide prevention program, but the suicide prevention activities were per partes let's say, implemented in Slovenia. As of 2018, as Julia said, we have a national mental health program on mental health with 6 priority areas, one of them being suicide prevention. And the national mental health itself is very multisectorial, incorporating mental health promotion, network of services, alcohol reduction, research, and so on. So basically, our suicide prevention efforts within this national mental health strategy are more or less trying to bridge the gap and enhance the collaboration between the sectors which are important in the field of suicide prevention. I'm speaking about schools, collaborating with the media, collaborating with healthcare services, with the users of these services, and of course with the NGOs. Yes, so and I believe that like trying to breach this gap, having suicide as one of the indicators, perhaps last in the sequence of mental health indicators, incorporated in the mental health national mental health program, is a good basis towards a multisectoral approach to suicide prevention.
Thank you so much. And passing to Denmark, multisectoral collaboration for suicide prevention is ensured by a high-level leadership, which is then declined to local context. So, Dr. Erlangsen, may you spend some words on describing this strategy and how different stakeholders are involved in?
Yes, hello everyone, and thank you for putting focus on the importance of access to care and sharing experiences within Europe. So in Denmark, we have a national plan for suicide prevention. We got it last year, and it's been after many years of trying to achieve that. I think one of the goals why we got it was because WHO and the United Nations have underscored the importance of suicide prevention and put forward goals that helps us to motivate. And we were in the situation that Saskia is describing of trying to put a connection between people who want to prevent suicide, as you say, just setting up things because we can see it's important. But at the same time, we also knew if we get the government on board, we can put structures down, we can put priorities. It's a much better way of moving forward. So I wish for you, Saskia, that you will get a national plan again in Slovenia. I know you had one earlier. So in Denmark, we now have a national plan, and there was also some funding allocated with it. And with that, there was also put down a national council for suicide prevention, which is run by the National Board of Health. And there's about 35 members in this council. They're representatives from administrative units like the Ministry of Health, the Danish regions, the municipalities. There's also occupational representatives, so from the doctors, the psychiatrists, psychologists, and we also have patient organizations from the field of suicide prevention. We have people with lived experience on board on this council also, and a lot of clinical groups who are working in the field of suicide prevention. So this group facilitates that we can identify problem zones and we can do something about it. So one example is we have put a lot of focus on individuals who present with a suicide attempt in emergency departments. We know this is a high risk group for suicide. And unfortunately, we know from the people in the field that not all of them receive adequate care afterwards. So this is a group we really want to put focus on. And because we have this network, we can now start discussing with the different stakeholders, what can we do? How can we set up a system where they don't fall between the chairs? Another thing which we have managed to start putting a more strategic effort to address is media reporting on suicide prevention. When we as researchers identify newspapers who don't put up a little box referring to help, we write to them and we tell them, please remember this. But it's a lot more powerful if you have the National Board of Health and the National Council who take contact to the media on a more overall level and remind them this is standard practice, this is what we do. So in that respect, we really have benefit from this National Council here, and we hope that it will grow more in the future, of course. So that's our news on that part, yeah.
Great, Annette. Thank you so much. This is very interesting. So, a collaboration with numerous individuals and organizations from diverse backgrounds needs a strong leadership. This is a very important key point for suicide prevention. So, I pass another time to Dr. Greg. Taking the example of Malta, how did you successfully manage to secure this cooperation between individuals, organizations, etc.?
In fact, this was a great learning experience for us because it was a process of collaboration. We believe that mental health does not only have the psychological and physical aspects, there is also the social aspect, cultural aspect, etc. So in the suicide prevention strategy, we wanted it to be an effort where not only us, the Department of Health, but all the different ministries and NGOs that are involved with humans at the end of the day get involved. So we have made a lot of contacts by writing letters, personal contacts, etc. And during the initial phase, we had around 30 meetings with people from the leisure industry, from media, from education. We had a lot from the police, etc. Once we developed the strategy after we collaborated with them, as I said previously, the strategy went into consultation process, and again, we have involved these people. In a way, it was a great experience because I think it was, if not the first, one of the first efforts where we wanted to pass on the message that mental health, it's not a question of the Ministry of Health or the Department of Health, but it's someone that everyone must have to be involved. And hopefully this network we developed while developing the strategy, it will be useful for future reference.
Thank you. So the other thing that we have to shed a light on is challenges that can be encountered along the journey of doing this prevention of suicide at the national level. So passing to Slovenia, Dr. Roskar, may you tell us something on what were the main challenges and consequent lessons learned you encountered during the process?
Yes, I would first of all like to thank Annette for her good wishes to be successful. But I also like to add here that we don't perceive it as a drawback that we don't have a separate national suicide prevention strategy, but rather embedded in the national mental health strategy because because we think everything we do now we could do it with a separate strategy. But anyway, thank you. So yes, what were our challenges? I believe that it comes down to the saying that all good things in life come in the right doses, and I think this was the biggest challenges we encountered. That we learned that there is a pitfall if we focus too much on just one aspect, on one sector. So either it is the sector of healthcare which offers help, or the other way around. So we try to address this challenge by somehow focusing on everything that is important if you speak in terms of suicidal process. So to enable access to care for people who really need it, and also to address the stages that come before the acute danger, with a specific emphasis on two aspects. One is the treatment gap, and the other one being the help-seeking gap. The treatment gap we heard a lot about today, so it's scaling up the accessibility. But I think that here it is important to emphasize that it's of course it's important to have access to care. This is beyond the shadow of a doubt. But I think that what we try to do is also to focus on the question why people don't use the healthcare that is available. What are the barriers for them to seek help? So it comes down here to raising awareness, to cooperation with the media, and we have media guidelines for responsible suicide prevention in Slovenia, to reducing stigma and so on. Because I don't know if you have an experience how it is to seek professional help. I do, and it is a completely different experience to sit in a waiting room for a GP or versus psychologist. And I think this is one aspect we also try to focus in our approach. So to encourage people to seek help when help is available. We have several programs in Slovenia. One of them are already mentioned, cooperation with the media guidelines. Then we have a great program called Mental Health First Aid, where we try to educate lay gatekeepers, not just the professional ones. So again, it comes down to bridging the gap between having help available and encouraging people to use it.
Thank you, Sashka. And yeah, so we passing another time to Denmark. We highlighted both in the Sandy's presentation, and then also Sashka was speaking about the gap But something that is very important is also the data collection and monitoring to feel a little bit or to deal with these gaps and also to do a better suicide prevention planning. So, Dr. Erlandsen, may you spend some words on how this aspect was developed in your country?
Yes, so in Denmark, we have individual level data from administrative databases, which we can link together. So we have possibilities of doing a lot of follow-up on people of interest. And we were very much motivated by the Live Life guide from the WHO, where they, in the appendix, also bring some suggestions on how we can monitor the efforts in a national plan. And of course, we are monitoring the numbers of suicide death and suicide attempt by a specific group because it's very important. But we were also able to set up a database that has a lot of information. We actually made this data available online. It's called the FORSAM database, so FORSAM.dk, and it's available in English and Danish. In that one, we provide a lot of details about people who have died by suicide, but also suicide attempt. And we do it on different geographical levels, for instance, national and regional and on municipal level. And we do that with a purpose because we really want to reach out to stakeholders, and especially those ones we aren't talking with already. So it helps a lot to start that conversation, for instance, in a municipality by bringing along data to tell them how many people die by suicide in their municipality and who are they, not just how old and which sex they are, but also what was their daily life like. Were they living alone? Were they living with someone? Were they working or unemployed? Did they have recent stressful life events? Did they have sickness? And especially also, what did they have of healthcare contacts? For instance, how many of those died by suicide had contact to psychiatric hospitals within the last 6 months? And our data tells us that that's only 15%. So we're really missing out on a large group. But our data also tells us that about 80% of those who die by suicide, they did have contact to healthcare providers, but it was general practitioners or general hospitals. So in settings where they might not always be aware of suicide risks. So we really know where we got to reach out for people in that aspect also. And another thing that we are trying to implement in this monitoring system now also is the treatment gaps. So as I was mentioning before, people who have suicide attempt, now we will provide data going forward for those who have suicide attempt, describing how many percent did not receive care, follow-up care within 2 weeks. And that's we all agree they ought to have support, but we're also quite aware that it's probably a large group, maybe more than half, that don't. But by being able to quantify how many it is, we all of a sudden have it's more easy to engage the stakeholders in talking about, okay, what should we set up for these groups? So this is something we are very excited about going forward, how we can start using that to make sure that people get the care they should have.
Thank you so much. And this is a terrific, interesting about epidemiological data and how they can be used in a practical way to try to better tailor also suicide prevention strategies. So now is I will pass the word to my co-moderator, Jason, for the second panel discussion that he will introduce. So thank you very much for your presentation, and it was very, very interesting. Jason, the floor is yours now.
Thank you so much, Julio. And thank you all to our previous 3 panelists. That was very interesting, and I think it sets up nicely what we'll be talking about in this panel, which will be focusing more on postvention and bringing it from which we have been talking about more about national strategies, about the broad level monitoring of suicide deaths and attempts, and what we as as countries can do about it. And now we're going to move a little bit down to the ground level and hear from some people who have experienced suicide attempts or have lost somebody to suicide, as well as the what helped them and what can be done in a practical way for individuals. I'm joined by Dr. Jivile Valuknie, who is a cardiologist and expert by experience from Lithuania. Gali Marbo, who's a journalist and and also is affiliated with the Association for the Promotion of Self-Determined Use of Media from Austria, and Dr. John Meehan of the National Office for Suicide Prevention in Ireland. I would like to start with Jivile. Can you tell us a little bit about your experiences in regards to suicide, and with a focus maybe on what helped you through your recovery in the period after what your attempt.
Thank you, Jason. So 9 years ago, I unexpectedly found myself at the edge of suicide. And actually, not long before that, I had a very successful life, a thriving professional career in cardiology, and a loving family. But after the birth of my second child, I developed a severe postpartum depression, and I failed to cope. I didn't ask for help, although I needed it, but I believed I had to be strong and capable as usual. And eventually, I was hospitalized against my will by my family members and was treated with psychotropic medication. The side effects were unbearable, and in hospital, psychiatric treatment left me feeling dehumanized, devastated, and hopeless. A few days after the discharge, I attempted to end my life. And then and now, I feel that the actual psychiatric system had failed to see me as a whole person, not just a patient or a psychiatric diagnosis. This experience taught me how vital it is to offer compassionate, person-centered care for everyone, silently navigating through mental health struggles. And what I needed most throughout my recovery was understanding, empathy, and safe space to share my feelings without judgment, which I found in my family and outpatient clinics, talking to psychotherapists, my friends, and actually starting sharing my experience, my feelings, and how I ended up in this situation. Sadly, at that time, I got just a word, drugs, and a negative attitude and mental health stigma experience. So that's my story.
Thank you so much, Jivile. And thank you for reminding us that it is people who are struggling as you did are whole people, and they are not just diagnoses, and they are not just people to be treated, but they have their own experiences, and that's something that often systems may fail to account for. I would like to ask the same question to Mr. Marbo, who's going to approach it from a slightly different perspective. Gali, the floor is yours.
Thank you, Jason. I'm Goli Mabo. I'm from Vienna, and I'm the father of a young man, who died by suicide. It's about 6.5 years ago that my son Tobias died. And after his death, of course, his friends and we, the relatives, we have had hundreds of questions. Why weren't we able to realize that Tobias was not in a bad mood, but in a very hard illness? And why did Tobias not see anymore that we would love to help him as far as we could. I will not get any answers to these questions. I will take them to my own grave. But we have realized one point. If he would have had a physical accident, like breaking a leg or something like that, everyone in our society knows how to handle such a problem. But if you have a psychological problem, no one knows how to handle, or less people know how to handle. If someone is sad for weeks, or if someone is not going out anymore from his little apartment, or even worse, if someone is saying sentences who are not true, which are not true. And so we decided in our family and in my friendship area to help to bring this knowledge to the people. And because of my profession as a journalist, I was finding the scientific works of Thomas Niederkrottenthaler about the papageno effect. And I realized that communication in public is possible. And in addition to the thoughts Sibyl was saying that we need safe spaces, I want to bring it to unsafe spaces. I want to bring it to the public, and that was helping me a lot. Yeah, because of the reason that a father who lost a child has no other topic in mind than to speak about this catastrophe. And as a journalist, I started to write about this catastrophe. Of course, no personal special feelings. Of course, no intimate secrets of our relation or no details about the death of my son, but about this sadness, about this loneliness, about this situation that we are living in a society which makes so many people lonesome and which brings these problems to our world. And now I decided, of course, I realized that we are speaking in the last years more about psychological questions in our daily life, but we are speaking about repairing a problem, yeah, and we should speak about a society in which less people are getting ill, and that's my goal now.
Thank you so much, Mr. Marbo. That was, again, a reminder of how important it is that we treat this as a societal issue, because this is something that we all can contribute to. This is something that we all have the ability to, I wouldn't say normalize, but make a part of the generalized human experience, to ensure that it isn't something that feels like people can't talk about, that we put it into the darkness where it does not belong.
Excuse me, Jason, just one sentence. Postvention is prevention. And that's the reason why it's so important that we, as experienced persons who lost someone, we have to speak about it, yeah, to prevent others.
Exactly. Thank you so much. I'd now like to turn to Dr. Meehan, and moving up from these personal experiences to, once again, what Ireland has been looking at in terms of the needs and priorities of people who are bereaved by suicide. Dr. Meehan, could you talk a little bit about what Ireland is doing in this respect?
Yeah, thank you, Jason. Thank you, colleagues, for the invite today. And I'd like to just thank my fellow presenters for this segment, for sharing their unique experiences, which is indeed very powerful. Here in Ireland, we do have a full government approach to suicide prevention. And I'm privileged to lead an office called the National Office for Suicide Prevention that drives our policy, which initiated in 2015 and finished this year. And we've just completed an evaluation of that policy and moved into working with our Department of Health for a new policy, which is scheduled for next year. I want to reflect and I want to really enforce what both Lydia and Gully has said, is that postvention is not just a response to tragedy, but it's a real powerful prevention act that, in my opinion, fortifies an individual and communities and really signals the fact that, no one should be left alone to grieve. And I think that's so important. In Ireland here, although the suicide rate is reducing, we have over 500 suicides per year. And the estimated effect on individuals and communities, it's impacted nearly 60,000 people, That's families, wider circles, communities. So our call to action in Ireland here for our population is, and we have a population of 5.3 million in the Republic of Ireland, is that suicide prevention is everybody's responsibilities. But I'll give you an example of what we did here in Ireland as a postvention initiative. In 2022, we asked for the first time people bereaved by suicide about their experiences and needs. And we conducted a survey of people bereaved by suicide, which we called Afterwards. This was funded by the Health Service through the office that I lead, and it was conducted by colleagues here in Ireland in the National Suicide Research Foundation. And we went in partnership with an NGO called Healing Untold Grief Groups. Now, there's a lovely acronym to that. It's called HUG. And it's the first of its kind survey, which really aimed to examine and understand the profile and needs of those bereaved by suicide. There were over 2,400 people that contributed to the survey, and it was really evident that those bereaved by suicide wanted to tell their story in their own voice, and they wanted their voice to be heard. I suppose, listen, just a number of takeaways, and we can share that. It's online through our Connecting for Life, our website. But one of the takeaways was that suicide bereavement extends beyond the immediate family and friends. 54% of respondents reported multiple losses, not just by suicide, but also had experienced grief in other ways. Young adults and professionals experienced suicide loss as part of the roles. They really needed tailored support. 53% of young respondents reported suicidal ideation. And I think the impacts of suicide are wide-ranging and complex. 93 of respondents stated that loss had a major and moderate impact on them. I think, proactive outreach and signposting are key elements, and that was being brought up by other colleagues here today. Over 30% of respondents felt that no supports were offered to them. 45% felt they could cope with things on their own. And as we heard, you shouldn't be alone with this. And 30% were reluctant to ask for help. So the survey and findings really challenged us here in Ireland to rethink what is meant by suicide bereavement. It highlights the significant and enduring impacts on everybody, friends, family, work, colleagues, professionals, everybody who's experienced loss by suicide. But it also highlights how we need to work in closer integration and equip and empower everybody who come in contact with people bereaved by suicide. And it was mentioned earlier, emergency responders, clergy, GP, and school personnel. And I think the example, I think of Sanderson in relation to Australia was a great example, how we need to empower. And I know an example in Wales where they have empowered the local postmen in suicide training, because it's rural areas, just like what we have here in Ireland. And maybe the only time individuals, particularly men, middle-aged men, meet anybody could be through the postman. So that's just a little snippet of what we're providing here in Ireland, Jason.
Thank you so much, John. That was very comprehensive, very interesting. And it is always exciting to hear what Ireland is doing when it comes to suicide prevention. I've learned, and I think the world has a lot to learn from the approach, this very comprehensive approach that Ireland is taking. I'd like to turn back to Jivile, who has, after her experiences, you've been involved in a lot of anti-stigma work in Lithuania. Could you tell us a little bit about the work that you're doing and how that is related to your experience?
My personal story and recovery led and inspired me to dedicate myself to anti-stigma work in Lithuania. And today I coordinate the initiative Žvelk giliau. It means look deeper. This project focuses on changing how society views people with mental health challenges and suicide attempts included. We create spaces for open conversations where lived experiences are shared and where silence and shame are replaced by dialogue and understanding. We work with communities, professionals, and young people to break harmful stereotypes and encourage empathy. Why is this important for suicide prevention? Because stigma is often the greatest barrier to seeking help. Many, like myself, remain silent out of fear of judgment, discrimination, or being labeled as weak or not trustworthy, unstable. By reducing stigma, we create a culture where people feel safe to speak up, to say, I need help, and to be met with compassion. Ultimately, anti-stigma work saves lives because prevention is not only about policies and healthcare systems, it is also about building a society where every person feels valued, understood, and supported, and nobody even considers suicide as an option.
Thank you so much, Davile. I really look forward to hearing more in the future about this work you're doing in Lithuania. I think it sounds really important that you give that space to people to be able to talk about what they need. And having these types of community initiatives, I think, is something that countries need to invest more in. I now turn back to Gali. You have been involved in, since the loss of your son, in among other projects in Austria, those that are focusing on the Papageno effect, which you mentioned earlier, as this effect of responsible reporting and open reporting can, in fact, reduce the number of suicides in a given locality. Can you talk to us a little bit about the work that you've been doing in Austria?
Yeah, I want to mention two projects in short words. First of all, we are co-organizer of a media prize called Papageno Medium Prize, which is given once a year to journalists and media responsible persons who are writing an article or producing a video with suicidal prevention aspects following the Papageno effect. The Minister of Health is giving this prize to the journalist once a year. That's one aspect of our work, and our biggest project is called Mental Health Days in Schools. Our project is existing since 3 years now, and we have reached about 150,000 pupils in all parts of Austria. And we want to show that it is not a problem and not a stigma and not a taboo to speak about mobbing, about body positivity or body neutrality better. It's not a problem to speak about depression, about fear, about suicide. And we are doing this in the schools together with psychotherapists. And we have produced special videos typical to the age, not only to describe the type of psychological problems, but also to show peers. If we speak about depression, you have Raf Kamara. If we speak about suicide, we have Billie Eilish with a sentence, etc., etc. And these are workshops in open spaces character. Yeah, and the participation of the children is with Mentimeter. Maybe you know this interactive app, which gives the young people the possibility to bring them in anonymous way. And that was a game changer, because in a classroom, you have always the louder ones. Yeah. And if we do it by app, also the outsiders, the more silent persons are able in a democratic way to be involved in this point. And we are not only going to the pupils, we are only going in schools if we are allowed to make also a workshop with the teachers and in the evening with the parents. Because suicide prevention is not only a subject for young people, it's a society problem or a society necessity. And our idea is we are starting with 10-year-old children, yeah, till 20 about. And so this is the age of our children we are playing with, or we are giving these workshops. And our goal is in the year 2030, we want to have not only a party of sports once a year in our schools, we also want to have in every school in Austria a day of mental health. And we want to come back every year to each school to bring this to a regular topic. And after the workshop, the children shall say, we want to hear more about this and not to be ashamed.
Thank you so much, Gale. That was, I think, very interesting to hear about the use of especially Mentimeter and trying to be as inclusive as possible in these workshops. I think that it sounds like a really interesting initiative, and if you could provide some information in the chat, I think people would be very much interested in hearing more about it. Back to John. John, can you mentioned a little bit about what Ireland is doing about assessing the needs and priorities of people bereaved by suicide. But what projects can you talk to us about how you're trying to meet those needs at the country level?
Thank you, Jason. Since the introduction of our suicide reduction prevention strategy in 2015, we actually took an incremental approach, should we say, to the concept of postvention. In 2019, a project report entitled Improving Suicide Bereavement Supports in Ireland was compiled. This report set out 10 core actions areas and encompassed 21 actions identified as essential to improving supports. So really, I'll just give you an example of 2 of those, and I'll put the links up to this afterwards. The report identified the ownership of the actions that will allow for improvement and sustainability of services, and with the introduction of a national suicide bereavement support coordinator, and they were appointed as part of one of these actions. The coordinator now provides, and there are 16 part-time suicide bereavement liaison officers around the country. It's funded by the HSE through my office, and they're non-clinical, and we work in partnership with our NGO partners, Pieta House, and in one area of Ireland, a family resource centre. The coordinator provides a critical link between health services and agencies and providers on the ground to provide that better streamline plan that requires in the whole area of bereavement supports. They provide really a proactive, informal outreach, practical support and information for many people and their families, and indeed communities as a whole who have been bereaved by suicide. And they're available to meet a person and their family in their own home, or you can meet them in a place of their own choice. And they really assist people in finding pathways of referrals to other services or signposts to other services that are needed, both, a practical and emotional holding support, which the feedback is very very important and worthwhile, particularly at that vulnerable time in individual lives. We have resource officers. We have 22 resource officers all over the Republic of Ireland, and they're the crucial link between national strategy and local implementation of that strategy. The resource officers provide the nuances and the needs at a local level because they change in Ireland. We have both rural and urban settings, and there are key people, as I say, on the ground that implement a multi-task and a multi response with both health services, NGOs, emergency services, clergy, our Garda, our police force. So they have that multi-agency approach. And just one more, I'm going to give one more example, which we're all very proud of here. We're very proud to introduce Safe Harbour, which is a bespoke, homegrown, we like to call it, developed illustrated storybook for children who have been bereaved by suicide. And I think that was mentioned earlier about bringing it upstream. It was developed in collaboration with a network of bereaved experts, including professionals and people with the lived experience, to help, a child with their grief by encouraging conversation and developing an understanding of death by suicide. This illustrated book is a story told by a young child whose dad has died by suicide. It contains words and illustrations that a child can relate to, and it describes the journey that they go on as part of that grief. Since the launch, we have now extended the series to include a second version of the book, which the child's mum has died. And the storybooks are accompanied by a very guide and other carefully curated materials that help parents or carers to read this illustrated Safe Harbour book with their child and empower them to have these really difficult conversations. We've 3,000 copies distributed throughout Ireland to date, and we're developing that further, looking on new resources to expand the self-help offering to children and young people. And this has been, it's crucial. 50% of the funding in my office goes to our NGO sector. And working with what I've mentioned earlier with HUG, they're one of our really key stakeholders that support this, but it is to provide that reactive grief support and advice to suicide bereaved adults as well. So we have the children and the younger person with the illustrated book, but HUG provide that sort of raising public awareness of the impact of suicide on the bereaved and encourage lived experience participation in post-vention research. Thank you.
Thank you so much, John. And I had the privilege of working on disseminating a bit the Safe Harbor book. I think it's a very powerful and very interesting and very needed endeavor. I remember in talking to somebody who I believe advised on the book, mentioning the practical support that is needed, just the informational support, what is needed at the very basic level after what has happened is crucial. And I think it's something that, we never, none of us are probably expecting to ever have to go through this experience. And so just providing that basic information about what happens next, I think can be absolutely key in helping people get through such an incredibly difficult time.
Thank you, Jason.
We unfortunately do not have too much time left. So I can see that my colleagues are answering questions in the chat. I'll return to my co-moderator, Julio, to end us for the day. If anyone has any questions, please continue to write them in the chat and we'll follow up with some answers later on.
Thank you so much, Jason. So we approach the closing of this wonderful webinar. So first of all, to the extent heartfelt thanks to all speakers for their openness, insights, and to all participants for their engagement in this webinar. So just to sum up, the discussion highlighted the necessity of multisectoral and multi-level suicide prevention strategies to improve care access, structure at national and tailor at local levels. Key factors included strong leadership, assessing barriers and enablers, data monitoring, and sensitive media reporting, just to give some examples. Additionally, addressing the needs of people with lived experience or bereaved by suicide is critical and powerful for effective strategies. This was very interesting point of this webinar for me. To date, I would like to share a meaningful quote from the WHO Director General for the World Suicide Prevention Day, reflecting the core of today's webinar. So we must move from silence to openness, from stigma to empathy, and from neglect to support. We must create an environment where people feel safe to speak up and seek help. Shifting the narrative on suicide also means driving systemic change, where governments prioritize and invest in quality mental health care and policies to ensure everyone gets the support they need. So thanks you all again, and have a great continuation of the day.
Thank you all. Thank you all so much. And take care.
Thank you.
Bye. Thank you.
Bye-bye.
Well, thank you.